today we're going to start on a very interesting topic of the confusion between diagnosis of type 1 and type 2 diabetes. Now, for last a decade or so, there has been a lot of rise as far as childhood obesity is concerned. And because of this, especially in the adolescent period, we are getting presentations which are confusing between type 1 and type 2. Making the right diagnosis is absolutely essential, because if we do not do that, there may be a risk of decay or unnecessary treatment with insulin. So what we'll do today, we'll use 4 specific cases which will look into the intricacies about when type 1 behaves like type 2 or type 2 behaves like type 1, whether this could be a possibility of a slowly progressive immune disorder. We'll also try to work up in terms of what are the clinical parameters which can help us with regards to making the differentiation between the two. What are the laboratory parameters in particular with regards to immune markers and beta cell functions which can help you on that regard. So case, a 16-year-old boy with polyuria, blood sugar was 440, HbA1c was pretty high, was mildly ketotic. So there was no decay per se, but there was ketosis which was there. Started on insulin therapy. BMI was 27 and there was a strong family history of type 2 diabetes in family. Now, Sayan, what do you think? This is type 1 or type 2? Mild ketosis plus minus DKA, obese with a family history of type 2 diabetes.
So just by these parameters, obese, not in DKA, I can think of a diagnosis of type.
Yes, but there was ketosis. So, but are you sure that this is?
No, we can't be sure.
So what would be the best step from here forward?
A test which will differentiate is GAD. But on clinical follow-up also, according to the insulin requirement, we can differentiate.
Okay, so what happened was that it was people got really excited that this child is obese. There was some acanthosis, there is a family history. So this is type 2. And of course, we see the requirement go down after some time. So it's honeymoon phase or it's really type 2. Their confusion was there, the metformin was started, sugars came down, insulin stopped. And of course, 1 year later presented with decay. So this is the confusion which is there. If you have an obese child with a mild level of diabetes, maybe some mildish decay, what is to be done in that perspective? And that's a major issue, because of course, if you have severe, rapidly progressive disease with ketosis, lean individual, persistent insulin requirement, that's type 1. If somebody is obese who has got acanthosis, mild hyperglycemia, non-ketotic, that's type 2. But what is in that in between setting that you want to look at in that perspective becomes important in that regards. And what happened in this case was that this child was GAD positive. And this really highlights the importance of doing autoimmune evaluation in somebody who is antibody positive. Now, what is the significance of if you have an obese child, let's say with a BMI of +2 SDS, with diabetes, mild diabetes, he is with GAD and without GAD positivity. Do you think there's a difference in their clinical course?
Yes, sir. If GAD is positive, then in if mild patient is obese, then it can be chance of that to goes toward the type 1 diabetes.
This is very important because there was a lot of confusion earlier, maybe a decade ago or maybe even 5 years ago, whether GAD is essential in somebody who is obese without ketoacidosis. So our earlier algorithm, if you see 5-6 years ago, we used to say if you have obesity, you did not have DKA, you did not require insulin, you think this more likely to be a type 2 diabetes. But because of these sort of cases which are now emerging, now there are clear-cut guidelines. If you look at the ISPAT guideline, it will say that GAD antibody is absolutely important. Individuals who are obese with diabetes, who are GAD positive, are much more likely to develop ketoacidosis, much more likely to require insulin on follow-up. And the other issue is, why are you so bothered about differentiating type 1 from type 2? One, of course, is DKA prevention. Anything else?
So in case if you are like unnecessarily giving insulin, there is a risk of hypertension.
Yeah.
And more importantly, the complicated thing which has to be done early in case of type 2.
It's very important, because type 2, 30% children may actually have hypertension, dyslipidemia, NAFLD, diabetic retinopathy, neuropathy, nephropathy. So you have to screen right away. And the other way around, type 1, you have to think of celiac disease, hypothyroidism, adrenal insufficiency. So that becomes absolutely important. So this case really highlights that even if you have a classical phenotype of type 2 diabetes, you have to do an autoimmunity association. That becomes very, very important from that perspective. So we all know that glucose regulation involves a combination of insulin production, which comes from the beta cell and insulin action. And these processes are pretty much linked with each other. Now, this insulin will cause the functionality, and this will of course depend upon the beta cell function. But if your sugar levels are very, very high, this will cause a problem of a direct effect of hyperglycemia on the beta cell. Hyperglycemia will cause what is known as glucotoxicity, and therefore diabetes of any form, beta cell function will be compromised. Now, Pratik, we know very well that only 5% beta cell function is remaining in type 1. What about type 2?
50%.
So already they also are 50% deficient by the time they come to you. And if they have very high sugars, HbA1c of 13-14%, you would expect that they will be glucotoxicity will cause their C-peptide levels to be low. So the first message which comes out of there is that low C-peptide can be there both in type 1 and type 2 diabetes. So what is the role of C-peptide in evaluation of this classification?
We know that C-peptide will be low, but then we have seen it is slightly higher in the type 2 diabetes more than type 1. That can help us.
So the role of C-peptide, as you very clearly mentioned, is not in diagnosing type 1 diabetes, it is in excluding type 1 diabetes. If your C-peptide is unequivocally high, and we'll talk about various figures and cutoffs, which Navin will talk about as to which makes type 1 diabetes absolutely diagnostic, which is maybe type 1 diabetes, and which is not type 1 diabetes. So therefore, C-peptide role is more of a excluding. High C-peptide will exclude type 1 diabetes from that perspective. Now, other thing to remember, of course, is that if you have very high levels of insulin, so when you have got hyperinsulinism because of obesity and insulin resistance, what does it do to the beta cell function? Does it affect the insulin production and the beta cell function as well? So we said glucose, if it's high, reduces it. But if your insulin is also high, what happens?
If insulin is very high, the insulin receptors will be desensitized.
And there could be exhaustion as well. So insulin resistance of any cause will also cause the beta cell exhaustion. And that's why 50% already beta cells are off in that perspective. Now, this brings to a basic question that while we say that insulin deficiency and resistance are the major poles as far as type 1 and type 2 diabetes are concerned, both of them have got both. And this is very important to understand. Individual with type 1 diabetes has got beta cell failure along with insulin resistance. Predominantly, it is beta cell failure, while somebody who has got a type 2 diabetes has got a predominant resistance, but also there is a beta cell failure which is happening in that regards. So this was the classic, very simple dichotomous classification that if you have type 1, you will be ketotic, requiring insulin, and lean in that perspective, presenting with DKA. Now, type 2 diabetes would be non-ketotic in an obese individual, which will be managed with oral medications, and this was a classical distinguishing feature. But now we know that in both of them, you will have a component of deficiency and resistance, and both pretty much work hand in hand. And there is an entire spectrum of conditions which may happen in that regard, starting right from neonatal, which of course we know that you should think of if it's less than 6 months of onset or less than 12 months without antibodies. Monogenic form, which will be more like lean individuals, 10 years and above with a strong family history. Latent autoimmune diabetes, which is a milder form of type 1, I would say, in older individuals who have got early sulfonylurea failure, and ketosis-prone diabetes, particularly common in African Americans, which seems to be, looks like type 2, but has got much more ketosis, which happens. Now, there is a very interesting accelerator hypothesis, which basically means that both type 1 and type 2 are actually the same disease. What they're saying is that you need to have some destruction of beta cell as well as some insulin resistance. If somebody is becoming obese, if the individual is obese, what will happen to the onset of type 1 diabetes? Suppose you are GAT positive. What will happen if you are obese? Will you have an earlier diabetes, or if you are lean, you will have earlier diabetes?
Obese having the insulin resistance as well. So the chances of the diabetes is high.
So this is one of the concept. This is only a theory. This is not a proven concept, that basically because of this obesogenic environment, diabetes is occurring earlier. So this is known as accelerator hypothesis, in that both are important. And that's why the key message here is that while we are talking a lot about classification, do not be too much stick with regards to just classification. Most important thing is to treat. So therefore, your initial goal is to avoid ketoacidosis. So I would say if you are in doubt, give insulin. Once everything else is sorted out, you can always switch over to oral medication. So very importantly, while classification is important, it is not your primary goal. The patient has not come to you to ask whether I have type 1 or type 2. He's there to correct the glucose to prevent decay. And that's why it's important to be specific in terms of treatment, which is there. So what we'll do today is that we'll talk a bit about how do we classify type 1, type 2, and these confusions which happen in that perspective. You can all go and have a look at our website, learning.growsociety.in, which has got a lot of videos available, and we'll be uploading these presentations there as well. There are a lot of courses which you can explore along with the courses for fellows and postgraduates. We've recently come out with Pediatric Endocrinology book, which has a comprehensive coverage, and we'll use our applications, which is going to help. And we are working on another very interesting tool, which Dr. Pratik will be talking about, which will allow us to interpret diabetes just by putting up a few basic clinical parameters. So this is what we have discussed, that there is a requirement of both insulin production as well as action, which is essential to achieve a normal glucose level. And therefore, there has to be a balance between insulin secretion as well as insulin action. Now, how do you assess insulin secretion?
By looking at the C-peptide levels.
Or what else?
Clients and hormone.
That is for sensitivity. So secretion, you can do C-peptide, or you can actually do insulin levels every minute. So you have a temporal first phase response, second phase response. That, of course, is a more sophisticated laboratory technique. But ideal when you talk about that is the insulin response first and second phase. C-peptide is a way to look at insulin secretion, and we are discussing that there is a concept of how much C-peptide increases with rise in glucose. So you have a glucose tolerance test. From 0 to 2 hours, how much C-peptide rises, delta C-peptide upon delta glucose, which will give you the actual information about how much store is there, how much reserve is there for beta cell. And that is a good thing. But if you want to use a single modality, C-peptide may be good enough in that perspective. And what is the best tool to look at insulin action? So insulin secretion, we said C-peptide. Insulin action? Yes. So you basically do what Manoj was talking about. HOMA-IR is a surrogate, but the ideal best tool is a euglycemic hyperinsulinemic clamp. So what do you do there is that you're giving insulin at a particular infusion, you're giving a glucose infusion, and you see how much insulin is required to control that particular glucose. So this will tell you that this patient is requiring 0.1 unit per kg per hour. This is requiring 0.12 unit per kg per hour to dispose of the same amount of glucose, which will mean that patient 1 is more insulin sensitive as compared to patient 2. This is a very basic principle of the euglycemic hyperinsulinemic clamp, which will give you the information. The surrogate marker is a fasting insulin, HOMA-IR, which is again a product of fasting insulin, and some of those agents, but these are not very reliable from an individual perspective. So disposition index is by far the most important factor to know. This is the amount of glucose a particular individual can dispose in a given time. So if I take 100 grams, how much can I dispose? If you take 100 grams, how much you can dispose? So what is this disposition index dependent upon, Dr. Pratik? Depends upon, of course, how much insulin you are producing, because life is not a clamp, because you are not a fixed dose of insulin. You will producing something else, I am producing something else. So how much you are producing and how much it is acting. So it is the net effect of both secretion and action. And the principle is that type 2 is mainly an action defect, but secretion is secondarily affected. Type 1 is mainly a secretion problem, but action is affected secondarily. And this is something which is important to understand from that perspective, which is critical. So now if you look at the comparison of insulin levels and insulin sensitivity, you will get a typical graph, which will mean that as the insulin sensitivity basically increases, the insulin level will come down. As the insulin level comes down, the insulin sensitivity will increase. So both are compensatory. So let's go one. This situation in which you've got very low insulin level and very high insulin sensitivity, which is a body's response to that, you will not develop diabetes, and this will be pre-diabetes, pre-type 1 diabetes. You can then, as sensitivity goes down, you will develop type 2. What conditions will cause decrease in sensitivity here?
So one is increased obesity.
Yes. Anything else?
Say infection.
So that's why you will have decay in the setting of a stress, infection, and all those things. So one is, of course, this obesity will shift towards the left side, or if you have stress, infection, trauma, whatever may be the basic cause. Now, if you have got a low sensitivity, but your insulin level is compensating, this becomes pre-diabetes, pre-type 2 diabetes, which is basically pre-diabetes in that sense. But if the insulin level comes down, so it is not high enough to compensate for insulin resistance, you will develop type 2 diabetes. And this, of course, will be a progressive phenomena. And Dr. Pratik has said 50% of beta cells are already lost by the time a child develops type 2 diabetes in that perspective. Now, just to summarize, diabetes can, of course, be deficiency or resistance. We are just talking about type 1 and type 2 here. We are not talking about other forms of diabetes. We had a big grand round a couple of months ago on that particular regards, which we discussed there. Now, the question comes is, we know that the problem is either at the level of production or action. How to assess? The one which I alluded earlier. So you can look at, first of all, if the whole pancreas is involved or not. So you can do a pancreatic function assessment using a pancreatic imaging. But remember, pancreatic imaging will only pick up fibrocalcific pancreatic diabetes or an atrophy of pancreas. Which form of MODY presents with atrophy of pancreas?
It's a required atrophy.
MODY.
So it is PDX1.
PDX1 is a completely absent state, but that is not a MODY, that's a neonatal diabetes. So 1 beta will cause atrophy of pancreas. It is not absent, it is atrophy. Yeah. Then fecal elastase is a better marker of exocrine pancreatic function in that regards. Now, beta cell function, we already discussed, you can look at either insulin and C-peptide. Now, we all know that insulin has got a short half-life. It is basically the blood level you are measuring, and the where it is acting is the portal level. It is unstable compound, while C-peptide has a long half-life, stable compound, correlates in the blood and portal blood. So, of course, C-peptide will be a better marker of beta cell function. Now, what levels to choose? Now, we will be talking about that in between. The other major issue is about autoimmunity. So, for autoimmunity, you can look at what are the things you can look for autoimmunity. So, one is the humoral immunity. But what is the basis of autoimmunity in type 1 diabetes? Is it cell-mediated or is it humoral? No, it's basically cell-mediated. So these antibodies are the effect of immunity. They are not the cause of immune damage. So it's basically a CMI based, and because of that, your antigens get expressed and then body starts to react. Just like if you talk about you had torsion, somebody has torsion, and then you develop anti-testis antibody, which will damage the other testis. If somebody has a Sheehan syndrome, some of those antigens get expressed and body starts producing antibody. So what you need to remember is that while humoral antibody is a marker of the disease, it is not the cause of diabetes. And that's why a significant proportion of patients may actually be negative for antibodies. What is the prevalence of non-autoimmunes, quote unquote, or negative antibody type 1 diabetes according to you?
10%.
10%, and in India it is probably around 20%. So this is an important concept to remember. Now this brings us to the question. We said C-peptide is mainly meant to exclude type 1 diabetes. What will be the role of autoimmune association? Will it exclude or include? Or what will it exclude? If the antibody is positive, what is excluded?
Antibody positive, then it will exclude type 2.
So that's important. So if C-peptide is high, it excludes type 1. If it doesn't exclude type 1, it may be an evolving type 1, but not a frank type 1. While if the antibody is basically positive, it is type 1. If it is negative, it will go more towards type 2. So if you now look at a 2x2 table, very simple, in which you say beta cell positive negative function and autoimmunity positive negative. If somebody has an autoimmunity with beta cell functions which is absent, this is classically type 1. Autoimmunity with beta cell preserved, this could be a honeymoon phase or progressing. It's an early stage of diabetes. GAD negative, antibody negative, no beta cell function, this will be
Still type 1.
This will be a deficiency primarily state, but you will only say type 2 diabetes if it is C-peptide positive and antibody negative. So this way, if you look at 2x2 table, you will be able to identify this very, very clearly. So autoimmunity you can assess with antibodies or HLA. HLA is more of a research tool than of any other perspective. And insulin sensitivity, we said you can use a clamp or a HOMA-IR, which can be used to identify that in that regards. So what we said is that you have to look at two things, autoimmunity and beta cell. Which one should be done at diagnosis, Dr. Naveen?
Both, but GAD would be a better thing because of the increased leukotoxicity. There may be a reduction in the C-peptide level. So ideally, we need to get a GAD.
So if you have somebody at diagnosis, if you want to do one thing, autoimmunity will be preferred. Why? One, you said there is a glucotoxicity. The second is that the prevalence of antibody tends to fall over time. So if you do after 4 years, it may be negative. While beta cell reserve is more for the long term. If your C-peptide is low at diagnosis, no meaning. If C-peptide is low at 4 years, really there is a meaning that this is definitely type 1 diabetes in that perspective. So autoimmunity is more like a predictor. It will say that, okay, you are either develop type 1 or you will develop type 1 later. C-peptide will tell you what is actually happening on that particular day in that regards. This is important. So autoimmunity is more for early in disease, GAD, IA2 and ZNPT8, and late in disease in which you can do C-peptide. Genetic studies have a limited role because they are not really predictor in that perspective. And this is the study which was basically done to predict diabetes, and what they show is that as the number of antibodies increase, if you look at GAD and IA2, the predictivity becomes around 86% would be the likelihood of developing diabetes, type 1 diabetes in that regards. So you cannot be 100%. So there could be some false positivity. There could be false negativity also. So every test has got its own limitations. But yes, 86% those who are positive will develop type 1 diabetes. And if you have type 1 diabetes, 80% will be positive. So that's roughly the thing that you have to think of from that regards. And this we already discussed that it is options are either to do an insulin level or a C-peptide level. And very clearly, insulin has a short half-life. It has a hepatic clearance, labile sample mainly for research, as we are discussing first phase and second phase. While you're talking about C-peptide, it is a more stable, longer half-life, portal status, a better clinical parameter in that regards. And insulin resistance, you can look at acanthosis, high insulin requirement, and low body fat will be the other marker in that regards. Just to summarize this final slide before we go on to the cases, the main differentiation is if you have an early onset, lack of family history, not much of obesity, severe disease with ketoacidosis, with autoimmunity, think of type 1 diabetes, while pubertal onset, largely in the setting of somebody who has a strong family history with acanthosis without the development of autoimmunity and HLA associations not being there, consider type 2 diabetes in that regards. A very important entity, as I discussed, is the possibility of autoimmune type 2. If anybody who has a classical picture of type 2, like obese, acanthosis, hypertension, family history, but yes, GAD is positive, they are having a much higher likelihood of having lower beta cell reserve, less metabolic features, and the need for insulin. So GAD antibody is essential in everybody who comes to you with adolescent diabetes.
Is it type 2 or is it a slowly progressive type of immune diabetes? So we recently had an 11-year-old female who presented with urinary symptoms and frequent UTIs. She had lost a lot of weight, around 4 to 5 kgs, since in the past 4 to 5 months. There was family history of type 2 diabetes. If you look at the anthropometry, her BMI SDS is 0.81, and that means it's more in the overweight category. The BP was normal, and there were no signs of any insulin resistance, such as acanthosis or skin tags. So initial investigation suggested there was a high blood sugar. It was a non-ketotic hyperglycemia, but the A1C was very high at around 14.3. The next step was the C-peptide level, which came 3 ng per ml, and GAD65 antibodies were 381 units per ml.
So in the 4 2x2 table, where will you fit into?
So we have autoimmunity, and we also have beta cell positivity.
So it's A plus
A
B
plus B plus.
What does it mean, Dr. Manoj?
Sir, it can be type 2 because of the grade is positive. But
Type 2.
Type 1.
grade 65, so it is flowing through.
Type
So
1.
this is more type
Autoimmune.
2, diagnosing type 2 will be very difficult. Even if she is obese with a preserved beta cell function, she is most likely going to progress subsequently in that regards. And if you look at the titer of GAD antibodies, if you compare to other patients, the titer is also pretty high. So this means that there is a definite autoimmunity. There is no confusion which is there in that regard. So this is A plus B plus.
Yes.
Now let's go one by one. Your case was?
Sir, my case was very clear, sir. It was basically
Now,
A minus and B plus.
So you had no autoimmunity and beta cell function was present. Your case
A
was?
minus.
So there was no autoimmunity and beta cell function was? Yeah. And your case
So
was?
mine was no autoimmunity, beta cell positive.
While this is
A plus.
autoimmunity with a beta cell which is present. So this is one case where I said out of all those 4, only one you can say this is type 2 very clearly. So this is very clearly C-peptide is detectable and GAD was positive.
Positive. So this is the main thing, though. Basically, what really happened after that. So this child was started on insulin. We have some osmotics, well, not osmotic, she has weight loss, and the HbA1c is very high, so started on insulin. And what happened, within 1 month, the insulin requirement fell to nil. And this was assumed as a honeymoon phase. And what is important is the honeymoon phase continued for a few months, like from August to Jan 2020, she was off insulin. A1C actually came down to 6.5. Now, in another 3 months, there were frequent hyperglycemia, so insulin was restarted. But following insulin restarting, within a month or so, there were frequent hypoglycemias and low insulin requirement was there, following which metformin was started. The sugars were well controlled on metformin, minimum dose of 500 mg. Following that, in April 2020, she was lost to follow-up for a long time, and she had consulted some outside practitioner and who had assumed it is type 2 and given her SGLT2 inhibitors for some reason. And following this, the sugars were not being controlled, and then she finally came to us at around August 2021. Then we repeated a C-peptide. It was 1.3 ng per ml. So it had fallen from 3 to 1.3. But what is peculiar is the GAD65 had risen from around 300 to 1696 units per ml.
What are the dangers of starting SGLT2 inhibitor in this girl?
Sir, they can have hypoglycemia. Not
So if you give SGLT2 inhibitor, what will happen to them? What will happen to their sugars?
So they can present euglycemic ketoacidosis.
This is very important because you have insulopenia, which is there. Her C-peptide is coming down. But the fact that you're giving SGLT2 inhibitor, you're decreasing the load from the urine, so your sugars are low, but other effects of insulin deficiency are persisting. You have ketosis, so you can have euglycemic decay. That is very important thing to remember from that. So SGLT2 inhibitor should not have been given at all in this case. And she became quite lean
Very lean. Yes,
when she came to us.
Sugars, no, she was started on, then after looking at these reports, it was quite clear. The C-peptide is falling and it's actually becoming beta negative and GAD-AB positive. So then it was falling to a type 1 or rather autoimmune diabetes and was started on a basal bolus regimen, following which now the sugars are under control. So now we are under this dilemma, is it type 2 or is it autoimmune diabetes? Now the points in favor of autoimmune is the age of onset, GAD65 antibodies actually rising, and sugars not being controlled on metformin. And points in favor of type 2 is the BMI SDS being overweight, family history of type 2, a non-ketotic presentation, and C-peptide suggestive of good result. Now we must keep in mind that each and every of these points has certain caveats, like the age of onset. Now we know she has pubertal, but many of type 2 is presenting prepubertal, as was mentioned earlier. And even at that pubertal age group, we are seeing type 2. Second is GAD65 antibodies. Yes, a rising titer of GAD65 antibodies does point towards an autoimmune, more in favor of autoimmune diabetes. Sugars not controlled on metformin, we can see that. That's why even in ADA it mentions go to insulin and even liraglutide if it is not being controlled. Now, BMI SD as being overweight. Now, what I want to mention from our studies or our data, what we have seen here, out of all the type 1 patients, out of 215 type 1 patients, we actually had 1 obese type 1 patient and 6 overweight type 1 patients out of 215 type 1. However, in the type 2 patients, 3 patients are actually in the normal weight category, not even overweight. So that is one important function. And one more thing we need to keep in mind, when they come to us, their weight is actually falsely low because they will gain weight after giving the medication. So that should be kept in mind. Second thing is family history of type 2 DM. I feel this is, unless we have a three generation family history, type 2 DM is present in almost all families. So it does not really count too much. Non-ketotic presentation, we know that type 2 diabetes, around 7 to 10% individuals may present with DK. Now, the C-peptide suggests of a good reserve. This was discussed by Dr. Manoj, and from that study, I would like to say that the ones in the patients who were diagnosed at type 1, their C-peptide were actually much lower, like 0.3 to 0.2 to 0.3, whereas type 2 was actually much, much higher. Rather than this points more towards than a type 2 than a type 1. Just because C-peptide is there doesn't, I mean, a level of 3 is not really indicative of a type 2 because it should be much higher in type 2 individuals.
Out of the 6 points that you talked about, the prepubertal age of onset, GAD positivity, overweight, family history, and non-ketotic presentation, which of this would be the most important that you would like to go for?
The GAD65 antibodies.
So I think that is a big message. If you talk about the single message coming out of the entire discussion is that GAD is essential. In anybody who has adolescent diabetes, do a GAD. If it is positive, consider immune diabetes. Other things can have any other addition.
So this child was diagnosed as slowly progressive autoimmune or the type which is called type 1.5 diabetes mellitus. Now I would like to present the experience of CD or Regency regarding type 2. What we have here, we have 25 more counting more patients of type 2, of which 18 boys were there with a mean age of 15.2 plus minus 2.5. They were followed up for a time of 2 plus minus 1.4 years. An important point here is that 4 patients actually went into remission, means actually off any treatment. They were maintaining sugars, even off metformin. But unfortunately, what we have seen, and this is an important point, that all of them ultimately went into a relapse, which is around 1.3 years plus minus 0.3 years after remission. And a very important point we found out is that the most important predictor of persistent metformin responsiveness is a decrease in BMI SDS. So if the child loses weight, metformin tends to act good, and we may not need to add extra medications to control it.
And the other big thing out there was probably that in patients, around 50% were requiring second agent within a 2-year follow-up. This is a very important thing. So adolescent diabetes is a progressive phenomenon. You are requiring second agents early. Main thing is to decline BMI. So your case sign is a typical presentation. Had diabetes, resolved in 2 to 3 months. So if you talk about this 3 months, this is a typical picture. But if he gains weight, he'll again go into diabetes. It is pretty certain from that regard. Most important thing to look at is age at onset, and we know if it's before 6 months, it is neonatal. Do genetic studies. If it is after 6 months, look at DKA at presentation. If DKA is present and the child is requiring insulin, this is type 1. Don't do any GAD antibody, no C-peptide, nothing required. If DKA was there, insulin requirement is not there now. Like our first case which I presented, do not rush, label as a type 2, do a GAD antibody. If the GAD antibody is positive, it is still type 1 or immune diabetes. If it is negative, think of a genetic study in that setting. Again, if you have got no DKA, again very important. Earlier we used to say, if you are more than 6 months, no DKA, obese, this is type 2. Now things have changed. If you are having an onset after 6 months with no DKA presentation, do a GAD antibody. If the GAD antibody is positive, it is immune or type 1, whatever you want to say. If it's no, look for obesity. If the obesity is there, it is type 2. If it is not there, do a genetic study. So I think essentially what you're looking at, three things. You're looking at age at onset, insulin requirement at baseline and follow-up, and obesity. But GAD becomes very important. So where do we not do GAD? Let's put it this way. Somebody who had presented with DKA and is continuing to require insulin do not need a GAD antibody. Somebody who has persistent insulin requirement beyond 0.3 unit per kg per day or beyond 12 months of honeymoon phase still requiring insulin, don't do a GAD antibody. And that itself is a big number. In our study, probably it's around 60-70%. You don't need to do a GAD antibody. But if you have DKA followed by no insulin requirement beyond 12 months, do a GAD antibody. Non-DKA, whether obese or not, do a GAD antibody. If you have a doubt, if your insulin requirement is very low in that perspective that you see. So this is the study that we are talking about. 215 individuals, out of which 125 boys were there. And we have developed a very interesting diabetes interpreter, which Dr. Sayan and Dr. Pratik were validating, which asks about very basic questions. Age at onset, DKA, yes, no, insulin requirement, what is there? And then based upon that, we then say whether it is type 1, type 2, what is to be done. And only 3 patients, the results were not concordant. So it was around 99% correct in terms of making a diagnosis. And the 3 were all who were non-overweight type 2, which is an important entity to consider in that regard. So this is something which is there. We'll just maybe summarize about the approach to management. That will be, and then we'll take a few questions on that regard. So when we talk about management, and this was discussed a bit, that it depends on the presentation. If your presentation initially is with DK, what will you do, Dr. Naveen?
We need to start with insulin.
So anybody who presents to you with non-osmotic symptoms and HbA1c is less than 8.5%, then maybe you don't need insulin. But otherwise, you have to start insulin. So you'll start metformin. And with metformin, what is your target HbA1c?
If it's less than 6.5, then we can.
So in type 2, you are talking about less than 6.5 in children. If there is improvement, you continue metformin. While if there is no improvement and metformin is not responding, what will be your second agent?
So we can shift to GLP-1 analog.
So either you can think of a basal insulin or you can think of a GLP-1 receptor analog, which is there. We have got very good use of GLP-1 receptor analog, which stops insulin also in many patients. Now, if the presentation sign is initially with osmotic, like your case, HbA1c more than 8.5%, you'll start basal insulin and metformin. And as you said, you increase metformin and gradually go forward. If there is no improvement beyond 1.5, what will you do?
So beyond 1.5.
5 unit per kg per day.
So we can increase the dose beyond 1.5 also, but we can also add basal bolus insulin.
You have to add bolus insulin because basal is not going to work beyond 1.5. When you talk about 1.5, what does it mean? 60 kg, you're giving 90 unit of Lantus. So you can't keep on giving much higher doses. So you have to come out, and 1.5 is actually a higher figure coming from recommendations. I will not wait for 1.5. As soon as you are requiring 50 units, 60 units of glargine, better to use a basal bolus, which is very, very important. Or you add in that setting a GLP-1 receptor analog. If there is improvement, you try to taper in that regard. If the child presents frankly with DKA, what will you do?
Basically,
So don't give metformin in the beginning because that will cause
lactic acidosis.
So acidosis will worsen. So add metformin after the honk is corrected or the DKA is corrected. And then with improvement, you decide whether there is improvement, you then try to taper insulin. If there is no improvement, you add a prandial insulin or a GLP-1 receptor analog. So this management basically looks into the presentation. So if you have DKA, start insulin, then step down. If you have osmotic symptom, no DKA, insulin, metformin simultaneously. If it is non-osmotic, only metformin, and that will improve in that perspective. So this is the overall aspect that we discussed about. So just to summarize the overview, the key issues out here is that BMI SDS, age at presentation, ketosis, and family history. These 4 are clinical parameters. Our study suggests a BMI SDS less than 0.2 excludes type 2 diabetes. So they may be normal weight, but they will not be 0 or less than that. That is important. Second important factor, of course, is GAD and C-peptide. So you take A positive, negative, B positive, negative, autoimmunity present, no beta cell type 1, autoimmune positive, beta cell preserved, honeymoon phase, autoimmune negative, no beta cell. This is a non-immune type 1 or an immune type 1 in which antibody is negative. Autoimmune negative, beta cell positive. This will mean that this patient has type 2 diabetes. GAD is essential before you label any adolescent as type 2 diabetes. Next, as we discussed, if GAD is positive, think of insulin requirement. That is very, very important from that perspective. And of course, depending upon the ketosis level, depending upon the osmotic symptoms, you decide whether you give basal bolus, you give insulin with metformin or just metformin. GLP-1 always as a second line agent becomes very, very important from that regard. So patient on sulfonylurea, can we do C-peptide? What do you think, Naveen?
So in case we can get a C-peptide delivered, but the assets, it will be
high because see, there are two ways of looking. In the initial phase of type 1 diabetes, and this is a very interesting case which we just saw day before yesterday, who actually is frankly type 1 diabetes, but is responding dramatically to glimepiride. The reason may be that he has got those 5%, 10% cells, and they are suddenly boosting up with this glimepiride. This is something which should not have been done, but was done by a practitioner, but still his sugar was 110. So if you do a C-peptide there, it will be falsely high. So ideally, you should not do with sulfonylurea because that will cause confusion. Dr. Rajib Das is asking, in case of lipodystrophy in type 2 diabetes, can leptin be combined with oral hypoglycemics? Of course, so leptin is the agent of choice and that really helps, but in the initial phase, leptin alone will not be good enough. In that setting, you may need a high dose of insulin. Oral hypoglycemics, difficult to manage. Pioglitazone may help because it causes the adipogenesis. Metformin may be helpful, but I would say if you use leptin, it is considered to be the best treatment, and within a month or 2 months, you will be able to take off other medications, because once you have enough fat which is there in the body, the system becomes much better in that regards. So I think we'll probably stop at that point of time. We'll be uploading this presentation and the videos on the website, and thank all of you for patient hearing. Now, Dr. Kanwal is asking about the role of dyslipidemia measurement and diagnosis. So very important question, very relevant question. I would say definitely in type 2, you have to look for dyslipidemia after metabolic stabilization, because if you do early, you will have falsely high levels of triglyceride and cholesterol, which will cause confusion. So after stabilization is the key word. So I think we'll stop at that point of time. If there are any questions, we'll take it up later on. How long GAD will persist? Dr. Rajesh TV. So as shown very nicely by the paper of the multicentric paper by Dr. Sanjeevi from Karolinska Institute in India, with time, the number goes down. But even at 5 years, 69% were positive. So it may persist, but the positivity comes down in that regards.